And why would you know, this is the one thing that freaked me out. When Judy said, oh, we need a tripod, Blanche, bring one of your tripods, because Dawn's gonna videotape it. I went, what? I was planning on showing up in t-shirts and jeans, you know. A little casual.
That's okay.
So, good morning, and boy, a little hectic getting here this morning, but this is just so much fun. I mean, you know, do you realize how unique we are? On a Saturday in August.
We're almost weird.
Yeah, instead of being
Yeah,
out on the
that's right.
boat, on the golf course, hanging out with our families, we're trying to get a little bit more information to better treat our patients. So I think that puts us in the 0.001% of doctors. So I congratulate you. It is absolutely an honor to be in your presence and to share ideas with you. This is what excites me. This is what I love. So today's lecture is going to be on IV vitamin C. My goal is to give you some information about why we do IV vitamin C, but then mostly to really get you to do it, so that you go home on Monday, you will feel very comfortable with it, and as soon as you get your supplies, you'll be able to go ahead and do it. So we're going to teach you that in the afternoon, how to prepare it. You're going to be making your own IV bags. I told my dental assistant, no, take everything out, but the docs are going to do it all.
Oh, are you allowed to do it as a dentist, or do you?
Yes.
Really?
Dawn, by the way, I did talk to Dr. Huggins about that. There are only 2 states in the country, in the United States, where dentists cannot recommend give a prescription for an IV vitamin C. Those 2 states happen to be Texas and Colorado. So if you're in Texas or Colorado, you have to have an MD write a prescription. Now, once the MD writes the prescription, I think the dentist can give it, but you must have an MD write the prescription, okay? We're going to review choosing a site, which ones are better than others, some of the problems that you can run into, which are not a lot, really not a lot, and then of course we'll have some time for discussion and other things. Okay, the rationale, that's the first thing we're going to cover. Tom Levy said, a lack of understanding can never negate a positive clinical result. This is so important for biological dentists because there are a lot of things that we do because we know we get results, the patients do better. Now there's some biological dentists that say, no, show me the science, show me the science. And if the science is not there, I'm not going to provide that service for my patient. Well, my answer to those kind of dentists is, you're more interested in covering your own ass than you are taking care of your patients. Case in point, there was a dentist in IABDM who stood up and said, Dr. Huggins' treatment of high electrical fillings coming out first has no credence whatsoever. There is no credence whatsoever to taking out fillings with the highest electrical charge. It really doesn't matter. And there's absolutely no science to break it up. And while Hal Huggins has been teaching this for over 20 years, that electrical matters, and when it comes to teeth, do matter. And lo and behold, he finally figures out the science. Now we've got plenty of science. Anybody who's ever studied acupuncture knows that electricity in the body is very important. And so now we have the science to back it up. So if we had waited to have that scientific proof, look at all the patients over those 20 years who would not have had the proper amalgam removal, okay? In case you don't know it already, I'm a Huggins trained dentist, and, you know, they call me Hal Huggins Jr., you know. I mean, I do it the way Hal did it, because when I first met him, he had already done probably 20,000 patients, and he was very successful with a lot of them. And I thought, well, he'd already made the mistakes, he had already figured out what was working, what wasn't working. Why should I try to reinvent the wheel? I started everything almost 10 years too late, so I was not about to start inventing my own protocol. Although I have to say, at this point, Blanche probably has her own protocol. You'll see, okay? So yeah, you don't always have all of the science, but when it comes to vitamin C, there actually is a lot of science out there. Okay, a lot of the work was done by Frederick Klenner, okay? Klenner in the 40s and 50s was using IV vitamin C to heal everything from gallbladder attack to polio. When patients came down with polio, he would put them on a very slow, continuous strip of IV vitamin C for days, sometimes 4 or 5, oh my gosh, maybe even 6 days, and then their polio would disappear. Interesting.
See the gentleman from Reidsville, North Carolina?
I have no idea.
Yeah, he is.
Yes, he's from North Carolina?
Yeah.
Okay. Vitamin C is the ideal agent to destroy bacteria, fungi, and yeast. So once you're injecting it directly into somebody's bloodstream, it's going to go everywhere. Okay? As opposed to taking oral vitamin C. The moment somebody takes something orally, you automatically have absorption problems, assimilation problems, you have limits as to how much is going to be absorbed, and you have the time factor also. So when you give somebody IV vitamin C directly, you're entering it into their bloodstream immediately. It also helps to eliminate any toxic chemicals or substance capable of poisoning the body, snake bites, chemical poisons, all kinds of things.
But Blanche,
And so he knew this in 1949.
question, there's some scary stuff coming up, and I'm a reader of alternative news as well as standard news, and this fall we may be faced with forced vaccinations for this bogus swine flu virus. I mean, they're talking about getting military
That's right.
in here to force you to take this vaccine, or else they'll take you off to a concentration camp.
Right,
I mean, this is serious stuff. Where Germany was in the.
That's right.
Will this, if we're forced to take it at gunpoint, will this help?
it will.
How about autohemotherapy? Because we don't know what's
Yeah.
in.
It'll help, especially if your cellular level is up to where it should be. Most of us do not have a cellular level where it should be. We're very deficient, and it takes some time to get it up to the intracellular level where it should be. Once you've achieved that, then if you have to get a shot, get the shot and then get another IV the next day. Absolutely.
And how about,
But you know me, send me to jail. Go right ahead.
You can put yourself on house arrest and I can send you that information.
Yeah, I will go kicking, I will go kicking and screaming.
they do.
Absolutely. I will go kicking and screaming, and I will encourage other people to do the same. If our forefathers saw what's going on now in the United States,
wouldn't believe
they
it.
would roll over in their graves
That's right.
Yeah.
and come back and haunt us.
Just an aside,
How about,
How about-
what,
how about the lipospheric vitamin C that's available now? That's supposed to be extremely bioavailable.
It is, and we recommend taking both,
Okay.
absolutely. And if you can't give an IV to somebody, you build up their levels of lipospheric. You start them with 1 packet, then 2 packets, and then 3 packets, because you gotta get over that, remember the absorption in the intestines thing. The beautiful thing about lipospheric vitamin C is because it's coated in fat, it passes through the cell membrane with no extension of ATPs. There's no energy extended whatsoever. So lipospheric vitamin C gets absorbed through the gut, enters into the bloodstream, enters into the cell without one single ATP being expended. Very interesting. So it builds up the cellular level very quickly.
Mhm.
Okay, so I recommend our patients to take both. Always be taking the lipospheric and do the IV.
will the autohemotherapy help that situation too? The virus thing?
Yeah, they all complement each other.
Okay.
They do. Okay? Sven Gorgi, I can't even say his name, I think that's it, Georgi. He was the one who was able to isolate the vitamin C molecule. And he says life is evident only when there is a transfer of electrons. First time I heard that comment, I went, oh, you know what, that is interesting. That is very interesting. The one who loses all their electrons is the one who dies. That's really what it's all about, electron transfer. There isn't a single event that happens in the body without electron transfer. Okay? So when you have health, you have free electrons flowing and fully, high capacity. When you have sickness, there's always less electrons. It's significantly impaired. Yes?
Have you heard of Dr. Bodo Kroner?
Yeah,
Yeah, with his bioresonance stuff.
right?
He says that that's what it is we're getting out of our nutrients.
Right.
And all this highly processed food has no electrons
Has
in it.
no electrons.
And he says you shouldn't use any electric motors.
Right,
Like
and
mixers?
if you buy the food processed already cooked, and then kill the last little bit in the microwave, you're really getting nothing.
Yeah.
As a matter of fact, you're getting worse than nothing. Because if you ate nothing, you would at least have your electrons. But when you eat this food, it robs your body of minerals and electrons, so you actually go into a depleted state. And of course, when you have death, all electron flow stops. Okay? Vitamin C is an important stimulus to the flow of electrons. It's not something that just keeps us from developing scurvy when we run out of it, which is what people always believe. Let it go. Probably my daughter.
Or mine.
Right. Which is why the RDA minimum daily requirement of vitamin C is so infinitesimally small. Okay, so just as dehydration requires water to prevent oncoming death, right? If you don't have any water, you're not going to live that long. You must have water. The disease state requires vitamin C to prevent oncoming death. So vitamin C is not just a vitamin. It's not just something that prevents scurvy. It's something that provides our body with electrons. Okay, like I said before, the RDA is very small, and it's only the amount to prevent scurvy. The optimal dose is the amount which is necessary for proper electron flow within the body. And dosing to bowel tolerance, well, that's what most people say. Well, how do you know how much vitamin C? You dose to bowel tolerance, but that's not always that accurate. And because what your bowels can handle may be a lot less than what the cellular level requires. Humans and hamsters. Humans and hamsters are the only two mammals that do not have the ability to translate the DNA code. We have the DNA code, we just cannot translate it, okay? And then, so therefore, we can't get the enzyme L-glucono lactone oxidase. Therefore, we do not convert glucose into vitamin C. That's our problem. Complete lack of vitamin C will create a plasma level of 0. If you remain at 0 for several months, then you develop scurvy. It's very painful. The person has a pale, bloated complexion. They will even have bloating of the legs. They start to swell up. They will be very listless. They don't lose their appetite. They do eat, but they get no vitamin C from whatever it is they eat. And so because they get no vitamin C, the disease continues. They bleed very easily, and of course, if no vitamin C is provided, it's death. If you look at the other vitamins in our book, yeah, they have problems, but they don't lead to death the way lack of vitamin C does.
The last couple slides, they're not in here. Is that right?
Yeah.
Yeah, they're out of order.
It's out of order.
They're out of order.
Oh,
It's in
sorry.
the back.
We had some problems collating this morning, but they're there.
Okay, cool.
They're just out of order.
Right.
Okay, Lind and Limes. Dr. Lind was called the father of nautical medicine. He looked at the sailors who were coming down with Lyme's disease, took one batch of sailors and said, okay, I'm going to give these guys 2 oranges and 1 lemon every day for 6 days. Okay? That was enough to prevent scurvy in those sailors. So you all wonder, well, why did he give it to them for only 6 days? Well, because that's how many oranges and lemons he had.
Seriously.
Yeah. Okay? Those sailors did very well, the ones who got the oranges and the lemons. He tried again also an herbal concoction with cinnamon and cloves and some different herbs, and those sailors still died, but they didn't die quite as quickly as the ones with no vitamin C whatsoever. Vitamin C is an antioxidant. It should be called that more than a vitamin. As an antioxidant, it cannot be substituted by any other antioxidants. Isn't that interesting? You can't substitute it with glutathione. You can't substitute it with vitamin E. You can't substitute it with anything else. And it's also the most effective antioxidant. Okay, it's also a chemical antidote. It renders toxins and poisons non-toxic or less toxic, which is why it's so important for biological dentists to give their patients vitamin C prior to having their revision, while they're having their revision, after they're having their revision. Very often people would ask Hal Huggins, when's the best time to give vitamin C? During, yes. After, yes. You know, yeah. Through that whole period of time, before, during, and after. It neutralizes endotoxins and exotoxins from microbes. So if a patient has a yeast infection or high yeast in their body, they have high parasites in their body, and the truth is, show me somebody with mercury amalgam fillings in their mouth, I'll show you somebody who's got parasites and yeast. By definition, if they've got those mercury on the body, they're gonna have the other two too. So, it increases the effect of cancer chemotherapeutic agents without increasing the side effects. So you have some patients who don't want to stop their chemo, they want to continue. Well, here vitamin C also is going to help them. It's going to increase the effect of the chemo without having them being nauseous and you know, losing their hair and all the other side effects that come with chemo. Calabrese. I always thought calabrese was an Italian dish. Can I tip that? The wrong one. There we go.
Yeah, I think you have one leg that is taller than the other. The leg in that back corner.
Actually, what'll help it is if you square it up. That's what the problem is. I've got one of these too.
Okay.
Let's just do this.
You're gonna edit
The rear end that I'm looking at right now, maybe.
We'll just do that.
There we go.
Mostly focus
Might
on-
end up on Facebook.
You hear that, Mike? Okay, now it's squared.
But it's not all on the thing. Oh, there you go. Go closer.
There we go.
Oh, you're perfect.
Okay, very good. Perfect. Good, good, good.
That's that.
Yeah, that's good. Thank you.
You need to lift that leg up.
We don't have a copy of that one, I don't think.
No?
No,
You should.
I'm missing a few of them.
Okay. Hey, Diane, would you mind
No,
making
no,
a
you
note?
got it. It's at the top of the page. It says vitamin C is a chemical antidote.
Yeah,
Okay.
it's here.
I'm trying to.
These last pages are backwards.
Okay.
So
Sorry.
start from the back and work forward.
Okay, so what Calabrese noted was that it removes the effects of insecticides, organophosphates, industrial hydrocarbons, benzene, chloroform, where do we get chloroform in dentistry? Root canals. Polychlorinated bisphenols, vinyl
Plastics.
chloride, and then of course the assortment that all of our patients have, arsenic, cadmium, cobalt, cyanide, fluoride, lead, mercury, and silica. And then Ruskin and Johnson in 1949 proved that vitamin C prevented the damaging effects to the heart and kidney by preventing the lowering of oxygen uptake by metallurides. So metals decrease oxygen uptake in the body. But if you have vitamin C on board and you still have metals, you don't get that decrease in oxygen uptake. Did you follow that? Okay.
So it's, even if the metals are still present?
Even if the metals are still present, vitamin C is still
It's
good,
still good,
because
okay.
it prevents the damage done by the metals. Morjanjic and Petrovic, must be some Russian boys from Scranton. In 1964, gave 200 milligrams, that's not a lot, of vitamin C to guinea pigs, and then injected them with mercury chloride. Do you remember a few years ago, the chemist from Dartmouth, I believe it was, Dartmouth University, she touched her finger with 1 drop of mercury chloride, and she was, I think she died in a few weeks. It didn't take long, 1 drop.
Double gloved and went right through.
Right, went right through. Okay? Those that continued the treatment for 20 days all survived. They continued getting 200 milligrams of vitamin C for 20 days. They all survived the exposure to mercuric chloride. Those that didn't continue, in other words, they got the first dose, but that was it. Those that didn't continue with the vitamin C, some of those died. Okay? So what he proved was that it's the length of time is just as important as dose. You cannot just give 1 large dose of vitamin C and expect it to perform miracles. Not going to happen, which is why Dr. Huggins has now changed his protocol. Used to be you had IV vitamin C while you were having your amalgams removed. Now he's saying you should have a second IV vitamin C the next day. okay? In our office, they continue getting it the rest of the week.
Do they get it, do you give IBC while you're doing the revision?
Yes. Yes.
What's your dosage on that, 50 or 100?
It depends on the patient.
Oh,
It depends on their history of vitamin C dosage. If they have very little vitamin C, if they tell us they've been taking 500 milligrams, which is a half a gram, then we'll start them at 25. If they say they've been taking 6, 7, 8 grams, 10 grams a day, we'll get them right going to 50. Okay?
You know, I can't help but have a problem with his recommendation to take out so much at once.
Okay.
I do one amalgam removal a month. I get mostly really sick people, and I had 3 people with ALS totally recover
Huh,
just by giving them, taking out one a month
right?
and getting them to take 5 to 8 grams of vitamin C a day and
5 to 8 grams, that's good.
a day,
Yeah.
and a lot of, you know, other vitamins.
Yeah.
And these 3 people, they had been diagnosed with ALS
Oh,
2
that's
months
very
before.
good.
2 sisters and a brother. Father and uncle had died, and the brother had died of ALS.
Right. How about that? Well, you know what, my attitude about that is when it comes to biological dentistry, we're all very, very good chefs in the kitchen. And there's lots of different ways to make a quiche. You know, and once somebody makes a fantastic quiche, it doesn't mean that the person next to you who made a different quiche is wrong. They're just as different. If it comes out good, that's great. So that's, you know, you're adding it now, you've got your own protocol, which is what happens to us after a while. You begin to develop your own protocol and figure out what works for you. So, I
Yeah,
don't think it's
because-
wrong that Huggins is wrong, because
No,
I take out amalgams all at once.
yeah.
One day, boom, clean house.
Mhm.
And we have fantastic success with our patients. But then again, like you, we're also doing IV vitamin C, we're also doing nutrition, we're also doing acupressure. The list is endless. It's not just amalgam removal. Okay, Doctors Wright and Cathcart did experiments with vitamin C, periodontal disease was cured, arthritis, connective tissue disease. All of this relates to what we do in dentistry. So whenever somebody asks me, and they happen to particularly come from the State Board of Dentistry, anybody asks me what's my rationale for providing IV vitamin C, I'm treating periodontal disease. I'm treating the ligaments around their teeth. Okay, so I have a hard time justifying it for a patient who's totally edentulous. Okay?
Yeah.
I tell people, I get a lot of people who call me up and say, you know, I want to come in for IV therapy. I say, fine, do you have at least one tooth? They must have at least one tooth. We do have to cover our asses to a certain extent. You have one tooth? Good, then we can treat you. Because we treat a lot of periodontal disease in our office. And when you do your examinations, by the way, I might as well say this now, so while we're on the subject, there's no such thing as the perfect mouth. When you do the examination, you always find some inflammation and make sure it gets charted, because that's what you're going to be treating with high-dose vitamin C. Inflammation due to periodontal disease. Okay? But they had success with glaucoma, ocular hypertension, and then of course, I didn't understand this part, the heat, stress, I don't know, heat and cold, I don't know how the vitamin C, I mean, the impression I got was that if you had high doses of vitamin C, you could handle the heat and the cold better. Well, that kind of makes sense when you think of the adrenal glands being the ones to respond to temperature changes and make all the changes in the body. Well, if the adrenal glands are loaded with vitamin C, they're going to function better. That makes sense. Bone fractures, of course, we deal with bone fractures all the time. Every time we're taking out a tooth, right? Food allergies, asthma, hay fever, bronchitis, ulcers, mental disease, multiple sclerosis, cancer, anaphylactic shock, and arterial sclerosis. When you take a look at this list, what you see is, okay, not vitamin C cures this disease, not vitamin C cures that disease. Just like with mercury. Mercury doesn't cause this disease. Mercury weakens the whole body. Vitamin C strengthens the whole body.
Could you also put down on in your records for bone fracture,
Mm-hmm.
if that's in fact what we're doing?
Absolutely.
I mean, perio disease.
Sure. And everybody knows about
Fracture.
Sharaskin. He's one of the few people who did study in dental school. Except in dental school, they didn't talk too much about his vitamin C protocol. But when he treated patients, he found that the people who had vitamin C had noticeable improvement in their periodontal condition, even seen on an x-ray, which I thought was interesting. You don't usually see improvement in periodontal conditions on x-rays until it's been treated for a long time, okay? And his patients were only given 1 gram per day. So again, you see how 1 gram per day very gradually builds up the intracellular levels of vitamin C. And that's my reference. You can get that book if you like. It's called The Vitamin C Connection. And this is the stuff we all really want to know. Hangovers. Beer and wine will decrease the amount of vitamin C in the tissue. Okay? Red wine does not. So whenever we do cavitation surgeries on somebody, we tell our patients, no alcohol whatsoever for 6 months. Because the day you drink that glass of white wine or beer or have a mixed drink, you're going to stop bone deposition for 24 hours, and there's no guarantee that the bone deposition is going to pick up after the 24 hours. Okay, and this is one of the reasons why. It depletes the vitamin C, so again, it's depleting electron transport in the body. 40 grams of IV vitamin C will neutralize a hangover. But, you know, who feels like getting up the next morning and going into the doctor's office for an IVC, right?
You keep it at home.
Yeah, right. Keep it at home.
You try to hook yourself up.
And if for no other reason, you should give vitamin C to restore the depleted levels within the tissue caused by existing mercury. So by definition, if somebody has a mercury filling in their mouth, they've got more mercury in their body than they should. You know, the average body can get rid of 30 micrograms of mercury. That's not a lot. That's what we can get rid of on average per day by doing nothing, just, you know, pissing and pooping it out. 30 micrograms is also what you ingest in the air you breathe and the water you drink. Nothing to do with food. Nothing to do with sucking on amalgams. So if you have just 1 mercury amalgam filling in your mouth, you're already, by definition, absorbing more than your body is able to excrete. And these are my references. I highly recommend you get each one of these books. Anybody know Sam Queen from Colorado Springs?
Oh, yeah.
Sam Queen used to give some fantastic lectures on detoxification and vitamin C.
Toxic footprints.
Yeah, toxic footprints. And I love this book, Chronic Mercury Toxicity. It talks a lot about vitamin C in it. And then Tom Levy, who is the MD cardiologist, now he's a cardiologist and a lawyer. He could sue himself. How about that? He could also defend himself. His excellent book, Vitamin C, Infectious Disease and Toxins, Curing the Incurables. And he talks a lot about the work that was done in the 1940s and 1950s. And here again, kind of, you know, shoved under the rug. Now, we don't want to talk about something that doesn't, you know, require a prescription and pills and, you know, staying medicated for years and years and years. I don't want to talk about that. Okay, so next thing we're going to go to, oh, any questions? Let's stop right here. Any questions? No? Okay, preparation. How do you get ready to give somebody an IV? And the supplies needed for IV vitamin C. Well, you got to have at least an IV pulp, right? We like the ones with the 2-bag holders. They actually make them with 4-bag holders.
Nail on the wall is not acceptable.
Nail on the wall is not acceptable. But I'll tell you what is acceptable. We have had some patients who have taken a coat hanger because they want to be someplace else. So you can take it, you can actually loop the top of the IV bag into the top of the coat hanger and then hang the coat hanger wherever you want. That also works for patients who insist on going home. You know, they don't want to sit in the office for 4 hours. So we take the coat hanger, put it on the coat hanger rack in the car that's opposite them and behind them, and have them keep their hand down. And then somebody can drive them home. Of course, we tell our patients, should you get into a car accident, you have absolutely no idea where you got that IV from. It just showed up. Okay? And you're going to need tourniquets. You're going to need something to sterilize the skin. Again, we used to use alcohol. We don't anymore. In our office, we have an ozone generator, so we wipe everything with ozonated water. You can use betadine too if you don't mind. Most people are very deficient in iodine, so a little betadine probably do them well. Of course, you have to wear gloves. and you have to have a prepared IV bag. And these are your suppliers, so these are the people you're gonna call. Merit Pharmaceutical is just a great company. Very, very helpful. And they send good gifts at Christmas, I like that. They really do. And Apothecure is where we get our Procaine from. Okay, the bag. Ringer's lactate versus sterile water. You're gonna hear people say, oh no, you should use sterile, don't use Ringers. Oh no, you should use Ringers. So let's go over the whys and wherefores of both of them, okay? What kind of a solution do you have in the different kinds of bags? Okay. An isotonic solution is one kind that you can have, and that's where the osmolarity of the bag matches perfectly the osmolarity of the blood, okay? The intravascular space likes this, and so anything that you're putting in through an IV will go through the blood vessels all the way around the body very quickly and then start feeding the cells, okay? Ringer's lactate or normal saline solutions are isotonic solutions, okay? So these happen to be my favorite, and you'll see why in a little while.
You say lactated Ringers is isotonic.
Is isotonic, yeah, both of these are isotonic, okay? Patients with liver disease will not be able to convert lactone into bicarbonate, okay? And that can sometimes be a problem. When I'm talking about liver disease, I'm talking about somebody who's got, stage 4 cirrhosis, fatty liver, they're on their way out. I don't know that you would be giving them an IV vitamin C anyway in your office, okay? But if you should get somebody like this who comes in, they're ashen to ashen green, yellow, that's what they look like. They're very puffy. You can see their face puffs, every part of their body is puffy. Those patients will increase the bicarbonate level in their blood, and their pH will go above 7.5, and that is not a good thing. This is why you want to know what kind of a bag you're picking, because you want to keep the pH of the blood within a specific range. So you don't want to have too alkaline a pH. Your body doesn't like that. Okay, hypotonic solution is where the osmolarity is lower than the blood. When I was in school, I used to think of it as less concentration. So if it's a less concentrated solution, follow me?
Mm-hmm.
Then the fluid is going to flow very quickly into the tissue because the tissue is more concentrated compared to the blood vessels. Should I say that again? You got it? Okay? Okay, so then what happens there is you begin to infiltrate, and the area where you're putting the IV swells the tissue up very quickly. Well, that's not good in a normal patient. It can be good for somebody who's incredibly dehydrated. For somebody who's very dehydrated, yeah, you would give a hypotonic solution. Okay? This is the most dangerous of the three to give because it can cause a very quick fluid change from the tissue, interstitial tissue, to the cells, very quickly, and then create a cardiovascular collapse because there's not enough fluid in the blood vessels. It can happen that fast. This is your water, your sterile water. Sterile water has no salt in it at all. So you don't use sterile water. I don't think it's a good idea. We're not treating somebody who's coming into your office because they're super dehydrated. Now, in the age of terrorism, you might be called upon to help out. And if you do see somebody who's lost tons of blood because their leg just blew up, and you see they're passing out, they're going into shock, yeah, then you would give them a hypotonic solution. Absolutely. So it's only for certain circumstances, okay? Not your everyday patient. Hypertonic solution is one where you have a higher concentration of solutes in the blood vessel than you do in the tissue. Okay, so what's going to happen? Blood's going to flow from the cells into the interstitial tissue and into the blood vessels themselves. This is good for a patient with edema. Their legs are swollen, they look like elephants. Well, yeah, it's going to move the tissue, the fluid, from the swelling into the bloodstream. They're going to be peeing like crazy. Again, It's not your job to treat these patients, except in an emergency situation. So we don't want a hypertonic solution either, okay? Oh, also, by the way, very not good for patients with diabetic ketoacidosis, because you don't want them peeing any more than they're already peeing too much. You don't want this for people with impaired kidney or heart problems. They cannot handle the extra fluid flow in the blood vessels. The kidneys cannot handle it. Okay, so now you understand why I use lactated Ringer's solution, okay? This is the formula for your bags. The lowest amount that we give patients, well, I shouldn't say always. We had a couple of patients. I had one patient, I know I'm jumping ahead. We're gonna talk about G6PD later. I did have one patient who had a very, very low G6PD, and she did have American Indian ancestry. Because she was so low, we were afraid to give her a large dose of vitamin C IV. She wasn't completely deficient, she had some, but she was low. So we made her a 5-gram bag, and she got that all day, all right? But most of our patients, we start them with 25 grams, and the patients that you're gonna be seeing today, you're gonna start them with 25 grams also, for several reasons. One, because we've been starting at 1 o'clock in the afternoon, and we don't wanna be there till 6, because we wanna go to dinner, right? Everybody nod your head, right? So you start with 25 gram bottle, and it comes, it's an ortho bottle, and you get this from Merit Pharmaceutical. You're going to put in 1 to 1.5 cc's sodium bicarbonate, okay? And 1 to 1.5 cc's magnesium sulfate. The sodium bicarbonate is to buffer the solution so that it's not too acidic. You want it right in the middle. The magnesium sulfate is put because some of the patients do get muscle cramps when you give them an IV, and the magnesium helps with that. And then 1 to 2 cc's of 2% procaine, and that's because we like the patients, and the IV does hurt. And if you get a patient who's, oh man, you've got a really thin vein, you've had it in for an hour or two, it's not swelling, but they're telling you that it hurts. Oh, it hurts, it hurts, it hurts. You can go ahead and squeeze in another cc of procaine, provided that the IV is going in very slowly. You can't give somebody too much procaine all at once. If you do that, their heart will stop, and that's not fun. Okay, so all of these are added to a 500 cc bag of Ringer's lactate solution. Okay, we don't actually get the Braun Excel anymore. These are the glass bottles. You're gonna get some patients who are gonna say, oh, I can't have plastic, can't have plastic. Well, we used to get the glass bottles, and then the company stopped shipping them to us because they said half of them would break on the way. Why they didn't ship them better? I mean, I order wine, and 6 little bottles of wine comes in a box this big, with plenty of egg crate all around it so that the wine doesn't break. Why they can't do it, I don't know. So we had to switch to plastic. And I've only had 1 or 2 patients complain about it. But it is better if you can get glass, better than plastic. If you're going to put in 50 cc's of fluid into this bag, you must take out 50 cc's first, right? Okay? So the very first thing you're gonna do is you're gonna hook your bag up to the pole. You're gonna hook up a line to the bottom of the bag, okay? And so you're thinking, okay, I'm gonna put in 50 cc's of this, and a cc and a half of that, and 2 cc's of that, 1 cc of this. Okay, I'm gonna put in about 55 cc's total. You've gotta let out now 55 cc's in the bag. So that you have room, before you start, before you do anything. Pour it out. Now you can do 1 or 2 things with that. That is sterile. So you can take that, put it into a cup, and use that to irrigate a surgical site, or pour it down the sink, either way. Okay? Okay, these are a little out of order.
If you order bags of Ringers in advance,
Right,
what's the shelf life on it?
a couple of years.
At room temperature?
Yeah, we keep it in a cool room.
Okay,
Yeah,
great.
don't let it get too hot. Same thing with the vitamin C, it has to stay dark.
Okay.
Okay. So what are the benefits of IV therapy? First of all, you're maintaining fluid in the body. Don't forget, you have patients who are in a high stress situation, sitting in your chair. So, adrenal glands are pumping, they're peeing more. You ever notice patients is like they're sitting in the waiting room for 10 minutes. Okay, come on in, Mrs. Jones. Okay, I go to the bathroom.
Yeah.
It's not just that they want to go to the bathroom and be relieved before they sit in their chair. It's because they really have to go. That's a clear indication. Patients uptight, nervous Nelly. You bet. Their adrenal glands are pumping, and they do have to pee. Absolutely. Okay, so you're maintaining body fluids. You want to make sure you don't have a patient in the chair that's going to undergo dehydration. You're maintaining nutritional support. Maintaining electron transport, that's really what it's all about. You get to maintain their blood glucose levels because you already have an IV in their hand. I mean, one of the probably pearls, one of my best pearls that I learned many, many years ago is that if a patient is not getting numb, it's because their blood sugar's too low. Well, if you have a sedated patient, and they're still squirming because they're in pain. Oh, geez. Well, you don't want to wake them up, sit them up, and give them a glass of juice. No, you can put the glucose right through the port, and you're all set. So if a patient's not getting numb, 90% of the time, it's because their blood sugar is too low. Get their blood sugar up, give them a little bit more anesthetic, they'll be very numb. And that works also, you know, in your everyday practice, when you're not doing IV vitamin C and you're not doing all of this stuff, you get a kid in the chair and they're not getting numb, sit them up, give them a little bit of apple juice or berry juice. You're doing two things. You're raising their blood sugar, and that's good immediately because the juice is absorbed through the stomach right away. But you're also shutting off their sympathetic and stimulating the parasympathetic. Because you're saying to the body, chill baby, chill, we're not fighting here. We're gonna have a meal. Life is good.
Do you know, I asked that very question to a board-certified anesthesiologist at the hospital at UNC, and he did not know the answer to that.
Why juice works?
Why the juice and about raising the blood sugar level,
Right.
why people can't. This guy's a DDSMD anesthesiologist, and it's Jay Anderson. And he didn't know the answer.
Yeah, that's why you're shutting down the sympathetic system. You're stimulating parasympathetic, which is all about relaxation and healing. So it's a very good thing to do.
So we should just have that in the reception area.
Well, yeah, but
Set
you
it
know,
up.
I live in Scranton. We have families with 10, 12, 13 kids. You know, it's probably the only city, second to the cities in Utah, that produce tons of children.
Wow.
Must be in the water.
Yeah, it's a Catholic thing. So there are lots of large families, and those kids come into our waiting room. I mean, we still do, we have the tea bags, and some of them just like start grabbing tea bags and shoving them in their pockets and taking the juice, and we just said, okay, so we need a little control here.
Right.
But you're right, all offices should have a little refrigerator with some juices on hand automatically. Anybody's not getting numb, you give it to them, okay? So you get to maintain blood glucose levels if you've got a port in there, very easy. And then you've got a port of entry for emergency drugs. I gotta tell you a little funny story, you'll bleep this one out.
No.
Oh, darn. The first time I had an emergency in my office, I had an IV vitamin C running through the patient, and we had to call 911. Well, Blanche freaked out. I'm like, oh, wait a minute. First thing they're going to do is ask me, why is it an IV? Take it out, take it out, take it out. I immediately took out the IV, put the pad on, held it. Just then, the paramedics come into the room, and he's looking at me, and he said, did you have an IV in there? I said, yeah, but I took it out. He goes, duh. He goes, you would have saved me a lot of aggravation if you had left it in. So now leave them in. And you just say to them, yeah, we just keep an IV and whatever. You know,
What was the
they
emergency?
don't know. Stop breathing. Yeah, we get patients like that. Yeah, it's just boom. The O2 stats drop down to nothing out of the clear blue sky. And so, we bring the patient back. You know, you have to do that. But then after that, yeah, I don't want them in my office anymore. I'll send them to the hospital. Go find out what's wrong with you. Right. Yeah, right.
That could ruin your day.
Let's see, we had another one. Yeah, it could ruin your day. We've had a couple of really real serious, people just, out they went. We had one woman who went into seizures for the first time in her life at 54. You know, serious seizure. And she hadn't even gotten into the dental chair yet. She was sitting in the back on IV. She had a seizure, she had a full denture, and so I immediately saw that she was regurgitating and having a problem. And so my husband came in right behind me, and I just said, John, get the denture out. And you know, my husband is, if you haven't met John yet, he's like Mr. Mild-mannered reporter. He's just the opposite of me. I'm hyper and I'm all over the place. John is very calm and collected. But in times of emergency, he's right there. And he just went in there and literally ripped the denture out of her mouth. And of course the vomitus came to the side, we tipped her head to the side, and we got her breathing again and got her under control. But boy, talk about scary. Out of the clear blue sky, this is a lady with a negative history. At 54 years old, has her first seizure sitting in the office. Okay, when you have an IV in somebody's hand, and you're going to do the sedation too, that's another whole course, you have much more accurate dosing. Just last week I had somebody send me an email. They said, what's the difference between Halcyon and IV sedation? It's the difference between putting a mint in your mouth and having a banana split. I mean, come on. This is two totally different scene. IV sedation, you're in control as the doctor. You have much more control over what's going on with the patient.
He can titrate it. You can't.
Yeah, you can
You can't
titrate,
take
you can
back the.
control. Once you put a drug in somebody's mouth, bye-bye, it's gone. And if they were given a little too much, you got a problem. You got a problem. And so, any questions on preparation? You're going to get to see some pictures in the next group of slides of what it actually looks like. Okay? You know what I think I'm going to do? I'm going to skip the pictures. I'll go back to that. And we're going to go right on and talk about what are the risks of IV therapy, okay? We'll go to the pictures later. Okay, risk of IVC therapy. Number one on the list is G6PD deficiency. Glucose 6-phosphate dehydrogenase. Remember that in the Krebs cycle? Where did I hear that once before? Right? Remember that in the Krebs cycle? Well, it's a genetic disease predisposing the patient to ruptures of their red blood cell. It's called a hemolytic crisis. Not a good thing. Okay? G6PD is an enzyme that's found on the surface of the red blood cell, and it prevents it from oxidative damage. Too much of an antioxidant given all at once will create a crisis. Now they say, I've heard everything from 1 in 5,000 to 1 in 10,000 people don't have G6PD. Maybe here in Northeast Pennsylvania it's 1 in 10,000, but I think if you move into more ethnic areas, you're going to find, yes, the numbers are higher. Okay? So, multiple oxidant compounds can provoke a crisis. Primaquine, which we don't give our patients, acetylphenylhydrazine, sulfonamides, and large doses of IV vitamin C. Okay? So who are the people at risk? Like I said, if you go to an area that's more ethnic, we've got African blacks, black Africans, which are two different groups, right? Mm-hmm. My husband would always tease about, you know, the golfer who's from
Tiger Woods?
no, the other golfer, the white fellow from South Africa. What's his name? Oh gosh. Anyway, let's just say for case in point, his name is Joe Smith. It doesn't matter. John would say, well, he's from Africa. He says, so he's here now living in the United States. So does his kids get a full scholarship because they're African Americans? I go, yeah, look at that. That's true. You got African Americans, who could be white or black. You got American blacks, and you got black Africans, two different groups. Then you have Mediterraneans, which is your Greeks, right? Indians, American Indians, and Eastern Indians, and then Southeast Asians. For some reason, these people are G6PD deficient. Okay. Cancer. While it has been shown that high doses of vitamin C IV in patients with advanced cancer can only be beneficial, They've done this over and over again. Patients who have cancer, who are on chemotherapy, who get IV vitamin C do very well. They do better with their chemotherapy. They just have a sense of well-being the whole time they're on therapy. But there have been a few reports that patients with large tumors will actually get the tumors made worse. And their cancer will get worse. And I think it's because the tumor cells die, so many of them die so quickly, that then the body has to deal with the toxins coming out of that. And so sometimes I wonder, well, gee, maybe they should have given them even more vitamin C to deal with the toxins coming out of the tumors. Okay, it is generally recommended to start patients with large tumors to 3 to 5 grams per day. Well, most of our cancer patients are already taking that. So that's why we can go ahead and jumpstart them with 25 grams. And then gradually increase them to a higher dose. And hydration is of paramount importance. If you're giving somebody IV vitamin C and their body is blasting away toxins, you've got to have a lot of water to pass that stuff through the kidneys without damaging the kidneys. Laetrile. Laetrile contains cyanide, which is normally detoxified by cysteine, which everybody here knows because we have the cysteine sulfhydryl bonds, right? We're all familiar with that. Which is sulfur-containing amino acid. Vitamin C, in doses of just 3 grams per day, reduces cysteine and thiocyanate levels in the urine. So there's a little bit of confusion here as if, well, if a person's on Laetrile, should we not give them vitamin C IV? Because then they're not going to be able to handle the Laetrile. And there are compounds, metabolic breakdown compounds of Laetrile that are toxic.
So do you not?
I would say no. I would tell, if I had a patient who was on Laetrile, and I have had in the past, I'd say, okay, it's either or. You can't do both. And the ones who were on Laetrile and stopped, they did very well. Of course, I don't treat cancer though. I only treat periodontal disease because I'm a dentist. Okay, what are the risks of IV therapy, any IV therapy? Always infection, which is why you have to wipe the area. You guys will know about that.
What about, can I get one, before we get too far?
Uh-huh.
The Laetrile,
Yes,
what about the oral vitamin C?
no, that too, because it's just as little as 3 grams a day, even orally.
Okay.
Yeah, it's a problem. Here again, I think they should be taking more, probably 200 grams a day.
Well,
Grams.
yeah, I'm trying to hold on to this here.
So risk of IV therapy is number 1, infection. You know you have an infection when you see a red line traveling from the point of the needle up the arm.
That's a pretty
And
good
of course the
sign.
patient is, yeah, that's a pretty good sign. Okay, and of course the patient, it's painful, it doesn't feel good, and usually you'll have swelling too. Infiltration, this is our biggest problem, and it's also our least significant problem. Because if a person has weak ligaments around their veins, then the substance inside the vein is going to leak out. Well, most of our patients are vitamin C deficient, so they're going to have weak veins. Okay? And so they're going to get some swelling. If you get some swelling in an area, just simply take the needle out, hold it for 1 full minute so that you know they're not bleeding, go someplace else, find a better vein. Okay? When I had my very first IV vitamin C in Colorado Springs, I sat there watching TV for a couple hours. Then I called the nurse over and I said, "Nurse, my arm's the size of a football. Is it supposed to be like that?" They go, "What?" Yeah, they were upset with me. I didn't know.
You didn't feel anything?
Yeah, I didn't know. It's supposed to be like that. Bleeding. If you penetrate through the vein, you're going to bleed on the other side. And so you'll also see a little puffiness. And then sometimes if you have to take a needle out because it's bleeding, you'll see a little blue bubble. You always, always, always tell the patient, tomorrow this is going to flatten out and be the size of a dollar bill or the size of a peach, whatever. Tell them it's going to be big. And it says it's just the blood that leaks down into the tissue. And then it's going to turn to black and blue, and then it's going to go from blue to green to yellow, okay? always tell them ahead of time. Because if you don't tell them ahead of time, the next day when they see that big blotchy area, they're gonna tell all their friends that you bruised them. Well, to me, the definition of a bruise is, yeah, somebody punched you in the arm. A bruise is a traumatic event. So I always tell the patient, I said, you're gonna get a big circle tomorrow, it is not a bruise. It's not a bruise, it's a leak. And your body will eat up the blood just the way it eats up a bruise, and you're gonna be all different colors. And I always make a big deal out of it. Ooh, look at this, you're gonna be a bright orange in a couple of days. And so then they're okay with that. You kind of reminded them, it's not a bruise. You know what they say, if you do great work, they're gonna tell 10 people. If you do lousy work, they're gonna tell 25 people, maybe 100. Okay, potential for allergy reaction with IV vitamin C. Because, especially with people who are highly allergic to corn, because guess where they get the vitamin C from? Corn. So people who have a real high allergy to corn cannot have your everyday Merit Pharmaceutical vitamin C. You're gonna have to get vitamin C from Apothecure in Texas, and that's beet juice vitamin C. Beet vitamin C is twice as expensive. And so you have to, if you have a patient who's high allergy, you gotta tell them, okay, we can do IV vitamin C, but it's gonna cost you twice as much. Okay? Yes?
Jeffrey Smith spoke at the Scottsdale Convention on the seeds of deception, the
Right.
book he wrote. There is no corn unless it's organic, which is still very rare, outside of white and blue, that everything's genetically modified.
All corn is genetically modified in the United States. That doesn't surprise me, because all
So,
bread is genetically
If
modified.
that is in fact, we're getting the pesticides
Yeah,
with
right.
that. So it might behoove us to spend a little extra
Extra
for
money
our
and get the
patients
beet.
and
Yeah.
do the
But then,
beet.
is the beets genetically modified?
No,
No, okay.
no, corn, soy,
No wheat.
canola, and cottonseed, and a few mangoes. That is it so far on the list. I'll keep you posted though.
Okay. G6PD insufficiency, we already reviewed. Every patient in my office gets a G6PD blood test, every one, because we live in the land of litigation. And with my luck, God forbid I ever got sued, you can be sure that lawyer's gonna know there was such a thing as a G6PD test, right? You know it's gonna happen, Murphy's Law. So have your patients have a G6PD test. Now, sometimes you have to work in a hurry and you don't have time to wait for the 2 weeks for the blood test. It's about a $60 blood test. If you don't have time to wait, we use muscle testing in our office. My husband will actually take the bag, vitamin C prepared bag, put it up against the patient's chest and muscle test them to see. So John is coming in today because we got a lot of volunteers to be stuck, not stuck, you know.
Nice, Blanche.
Yeah, to be poked and prodded by you.
that's not you, honey.
Right, and so, because of that, we asked John to come in and muscle test everybody, just to make sure. Okay, it's not 100% muscle testing, but it's better than nothing, all right?
So what, where do you get the blood test from? Or
Whatever lab.
any lab?
Yeah, most of the labs do it.
And it takes about 2
It
weeks?
takes about 2 weeks. Very often, we'll get their blood chemistries back, because we do a complete blood chemistry on our patients.
Yeah.
We'll get their blood chemistry back in 2 days, and then it always says G6PD pending. We have to wait for that.
Oh, okay, that's what I'm wondering, because I order homocysteine
Yeah.
too, and it's always a couple
pending.
days. Vitamin D's always a
Right.
couple extra days. Okay,
Right.
that's what I meant, okay.
Okay, and one of the other risks with IV therapy is that the motion of the patient has to be controlled. So you have to tell the patients, look, when you go to the bathroom, pay attention to the hand that has the IV in it, and do everything very slowly, because you're going to the bathroom with one hand, and if you just touch that needle, it's gonna move. And sure enough, anytime we get an infiltration, did you go to the bathroom? Yep, I touched it. They forget. So they get in there, they start moving around with the toilet paper and everything, and boom, they move it. So motion does have to be controlled, and if you're putting an IV in a difficult spot, in say for instance the antecubital here, well they not only have to not move, but they have to not bend their elbow. That's a little more awkward, so we prefer the hand to the elbow. Kidney stones. You're gonna hear this. People are gonna say to you, well, doesn't a lot of vitamin C cause kidney stones? Why do they say that? Well, vitamin C is metabolized to oxidize ascorbic acid, or dihydroascorbic acid. By the way, it donates 2 electrons when it does this, so you're getting, it's an electron donor, okay? The dihydro then becomes diketogluconic acid. Now I call that DKGH, then becomes lysonic acid, xylose, thyronic acid, or oxalic acid, oxalate. Well, when medical doctors looked at kidney stones were made up of oxalate. So therefore, they came to the incorrect conclusion that vitamin C causes oxalate, causes kidney stones. Okay? Because that's the end product of fully metabolized vitamin C. Okay, well, Curran and his cousin et al., Harvard University study, looked at 85,000 women over a 14-year period. High doses of vitamin C found no correlation between vitamin C dose and stone formation. And then again, he did it in '96 for 45,000 men. Found no correlation between high dose of vitamin C and stone. Okay, and Gerster in '97 found that there was a statistical correlation between high dose of vitamin C and a decrease in kidney stones. It doesn't make sense. Okay, want to take a quick break?
Yes, please.
Cool.
Okay, vitamin C IV. It's easier than you think, and the patients will love it, believe me. Okay, the very first thing, you never, never, never give anesthetic to somebody without taking vital signs. You never, never, never put an IV in somebody without taking vital signs. Okay?
Really?
Really.
So before you give, just if patients coming in just for a local anesthetic, you always do all that, okay?
Your state law mandates it.
I just automatically hook them up to the Criticare machine. The Criticare machine does everything. Okay, it doesn't take the temperature. My dental assistant does that. Does the digital thermometer, okay? You know, I think when I first started hooking patients up to the Criticare machine, I never realized, I mean, their heart rate's about 95, and then as you come at them with the anesthetic, it goes up to 105.
Yeah.
I had, you know, because you can't tell by looking at them, they look like they're perfectly okay. And their heart is going boom, 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 boom,
Yeah.
boom, 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 you know? And so, you know, now knowing that, you know to give those consoling words and try to get their heart rate down, try to get their blood pressure down. And of course, if somebody's blood pressure is too high, which means their diastolic is higher than 100, they're not getting treated that day. Period. You know? Period. I have rules that I follow in my office. Your diastolic's above 100, bye. Yeah, you're not going to have a cerebral accident in my chair. Go to your physician, get your even if you have to take medication, I tell them, because they're so anti-medication, even if you just have to take it for a short time, just so I can treat you, you have to do it. Okay? So, you're going to find almost all of your patients have low body temperature. Why? Because they have mercury fillings in their mouth. Okay? If they have mercury fillings in their mouth and they have root canals, they're going to have a low body temperature because they're losing the war and the body is conserving energy. So we always tell our patients, you know what? Your body temperature should go up 1 degree tomorrow. And they love that. That's great, because when they see that 1 degree increase, they know they're on the way to recovery. Okay, so we hook them up to the machine. Here's the pulse oximeter. Okay, blood pressure cuff. And you're getting the mean arterial pressure. So you want to make sure when you put it on the patients, and this afternoon you'll be doing this, you make sure the little circle is right over the artery. Okay, that's my Criticare machine. If anybody would like to buy it, I'll sell it to you because I want to go on to the next bigger model. I want the model that shows the EKG also. Okay. So.
Make
I
sure,
love
make
this.
sure it prints out a strip as well.
Yeah, the red
Mhm.
strip, this has a strip that comes out the back.
I've got 2 of those.
You'll get to the point where you'll hear the machine, you can tell when somebody's O2 level has dropped just 1 point. Cause you'll be beep, 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 you know. So you don't even have to look at the machine. But if you pay attention to the bells and whistles, it's a great machine. If you're gonna ignore the machine, then why bother, okay? There was a dentist, oh gosh, we're going back about 15 years, but it's still an interesting story. A dentist in Dallas, Pennsylvania. Pennsylvania is an interesting state. Sometimes I think maybe half the names of our cities were taken from someplace else. So we have Dallas, Pennsylvania. We've got Jersey Shore, Pennsylvania. We've got Brooklyn, Pennsylvania. How's that for confusion? You tell somebody I'm going to Jersey Shore. Well, they think you're heading east. No, you're going west. How's that for confusing?
Wishful thinking on that person.
Yeah, wishful thinking. Anyway, so this guy in Dallas, Pennsylvania had a kid, a 6-year-old kid, hooked up to the machine. The machine had all the whistles and bells working, showed that he had stopped breathing. The dentist wanted to finish the filling. The kid died. He got his hand slapped. He had to give up his license for 2 years. He's back in business. Now, what would they do to us, biological dentists? Right? Yeah, he's back in business. So you have the Criticare machines, and I highly recommend these babies. Listen to them. Listen to the sound. Okay, so this is what your vitamin C bottle looks like. Okay? From Merit Pharmaceuticals. And the next step you're going to do is look for a vein. Now, a lot of times, patients will come to the office, and they have, because you tell them no eating, they also think that means no drinking. So they come to the office, they're already dehydrated. So as soon as they come in, if you can't find a vein right away, give them a couple of glasses of water and put a pinch of salt in the water so that they absorb it well, okay, and hold on to it. I've also had patients walk around the block. You get some people who have a lot of fatty tissue here, and their veins are real deep and they're really hard to find. Give them a couple of glasses of water, have them walk around the block. That will bulge up their veins, okay? Okay, so what do we look for? There's 2 large veins coming down the hand pretty much all the time. You've got the right dorsal metacarpal, the left dorsal metacarpal, and the cephalic is the one that runs right along the side. And I call it the one on the right, the one on the left, and the one on the side. Much easier to remember, okay? This one, the one on the right dorsal metacarpal, is usually your strongest vein. It's on the outside, it's usually the easiest one to get to. Okay, when that doesn't work and I don't see anything in the hand, then I'll go to the dorsal because it's a big sucker. Problem with the dorsal is that you want to try to go as high as you can so that the needle is not resting right at the elbow. Especially if they're golfers, see that's a golf swing. Okay, you don't want a needle resting right there if you can avoid it. Okay? So you're gonna find your vein and you decide, okay, this is the baby I'm gonna go for. Right there. Now remember, this is a patient who's deficient in vitamin C, right? So their ligaments around the veins are gonna be loose and flaccid, right? So you wanna be able to hold that vein and hold it tight. Think of it as a squirming pig that's been greased with fat, okay? And you gotta hold it and hold it tight. This is where you hurt patients, when you don't hold the vein. Because you'll penetrate into the skin and the vein does this. Whoa, whoa, no, you're not gonna get me.
It's like trying to pick up a worm.
Whoa, yeah, yeah, okay? If you hold the vein tight, when you penetrate the skin, you'll go right into the vein at the same time.
You ever tried paperclip?
Paperclip?
Mm-hmm.
Paperclip the vein?
On the ambulance, if you're bouncing around, the
Yeah.
patient's moving, you put a paper clip on the side because sometimes the vein will roll. I mean, even though you're trying to stretch it out and hold it.
Skin?
No, you just lay the paper clip on the skin while you're stretching and holding the skin
Oh.
taut, but the paper clip is parallel to the
Right.
vein
Right.
and it keeps it from rolling.
Hey, that's a great
Oh,
idea.
that's a nice little
I like
pearl.
that idea.
See, that's why we come to these seminars for the journals.
Yeah, I like that idea, a little paper clip, okay? Oh, now this, don't you wish all your patients had this? All right, look at this. He's got 7 veins I could choose from right there. Nice. Okay, there's another one. Sometimes if the patient doesn't have this one, sometimes it'll anastomose and connect with the left dorsal, okay? And this area, when it does that, this area is the best part to get. You're coming in off the side, and you don't want to dig the needle in too deep, but that's the best place to go because it's large. Also, once you put the needle in, you don't have to snake the needle all the way up the vein. If you do that, you run the risk of penetrating the opposite side of the vein, and now you've got a bleed through, okay? What you want to do is hold the vein tight, like I said before. Paperclip idea is a great one. Hold the vein real tight, penetrate as soon as you feel it enter into the blood vessel. Stop. You don't have to go any further. Lay the needle down, put your tape on. Stop. It feels like you're going through a hot dog. Now we have some tourniquets in the office that I tested. These special tourniquets really do feel just like a vein. So if you want, you can practice sticking the needle in the tourniquet first and get an idea what it feels like. We were clowning around the office, we were thinking of putting ketchup inside the tourniquets so that when you enter, it would squirt out. My son was shaking his head. He's my bookkeeper, he's shaking his head and going, you guys are crazy. Okay, there's the dorsal one. This is a great vein. I love this vein. But you gotta be able to enter over here. See, the vein is here. You gotta be able to enter a little higher. Because if you enter here, now the patient is right at the bend of the elbow. They're gonna move it, you can be sure. Okay, if all else fails, then you use the antecubital. That's the big vein here. A lot of patients will say to you, oh, they always use this vein. This is my good blood-giving vein. Well, that's nice. That's if you're giving blood. It's not a great vein to take stuff. There's a big difference between poking a big vein to just suck out some blood and leaving a needle in there to give them an IV, okay? So you have to explain that to them. Yeah, that's good for giving blood, but not for taking. If you go with the antecubital, then you're gonna have to learn how to use the catheter needles. The catheter needles are different than the little butterfly syringes. I love the butterfly syringe. It's a short needle, it's a little less than an inch. It's got a little blue butterfly that you hold up, plastic, and bing, you're in, you just tape it down, you're all done. With the catheter ones, because there's a potential for the patient bending their wrist here, you've got to put a catheter one that's plastic. So how do you get a plastic tube in a vein? Well, the plastic tube has a needle in the middle of it. So, and all you can see is a little teeny tip of the needle. You penetrate with the needle. As soon as you penetrate, you slide the needle out at the same time you're pushing the plastic in. Okay, a little tricky. You gotta feel comfortable doing quite a few butterflies before you can go to the catheter ones. Catheter ones is what they use in the hospital 90% of the time. Again, you'll push it in. As you slide the needle out, you push the plastic in. And then you tape that down. Now if the patient bends a little bit, it's okay. They still can't bend completely like this. They'll stop the flow. Okay? Okay, this is what we do in our office, and I'm amazed at the patients that say, oh, gee, how come they don't do that in the hospital? They don't. They don't have time, I guess. But if you put a heating pad on the patient's hand, 10 to 15 minutes, you will dilate the blood vessels. Duh, that makes it easier for you to put in the needle. That's great. So all of our patients, when they come in, they know. They walk in the back, boom, they sit down, they put the heating pads on themselves. They know.
Now, do you leave that on during the duration? Because that's one of my complaints when I have IV hydrogen peroxide, is that my arm gets so cold.
Yes, you can leave it on, but it has to be above the needle. You cannot have the heating pad directly on the needle, because the needle is metal, it will heat up the needle. So we've had patients who've done that and go, boy, it really hurts now. I go, yeah, no kidding. You're heating up the needle. You're getting little bubbles. You're boiling your blood. It has to be right above the needle. And a lot of patients really do feel comfortable if you leave the heating pad on, because then it dilates the blood vessels up here, and so you get better flow. Okay? So yeah, in answer to your question, we do leave the heating pad on for a lot of people. Okay, so now we're gonna make our IV bag. Like I said before, you have to create the space for the medicaments. All right? So the first thing you're gonna do is put the bag on the pole. Here's the pole. Becky hooks up the bag. Then you're gonna hook up your line tubing. The line has a very large plastic pointy part here that you'll stab the bag with. Now, those lines are of a very specific length. That's the amount of air that you can put into somebody's vein and not kill them. Okay? Does it mean that we want to do that? No. But it does mean if you happen to see a bubble in the line, don't lose sleep over it. They can actually have that whole line of air in the vein without hurting them. Not so of an artery. All you need is 1 cc in an artery. It's a great way to kill somebody instantly. Okay? So air is okay in the vein, not okay in an artery. All right? So now we've gotten our line hooked up. That line is completely filled with air. And we want to get rid of some of that air. So we'll squeeze the bubble here, and some saline will go into this. And you might want to squeeze it again a second time. I like to see it filled about halfway. Just because that's my point of I'm comfortable looking at drops. Once you see it about halfway, now you're going to open the other end and pour out 50 cc's. Let me see what the next picture is. And she is pouring it out into the sink, because she doesn't need it. Okay, I don't see it. I'm looking for a picture of the bag. Okay, can't see it here, but this on the bag, there are lines here. And each line is 100 cc's. So, if the fluid level is at 100 cc's, and I'm going to take out 100 cc's, well then I'm going to move it down to 2. I'm going to take out 50 cc's, I'm going to move it to about the middle of those 2 lines. So when you open the top, the other end, and you're pouring it in the sink, or we're going to have you pour it into a bucket today, you're watching the top of that line. You're watching it flow, and when it gets to where you want it, you're going to press the clamp and close it off. Do you get that? Okay? So you have to get rid of 100 cc's if you're doing 50 grams. You have to get rid of 50 cc's if you're doing 25 grams. Then you're going to play tug of war. Now we're going to put the vitamin C in the bag. You'll be shocked when you open these bottles up, okay, and put the needle in. It's like, doesn't the vitamin C want to come out? It's a real tug of war. So we recommend that you take your large 60 cc syringe, that's this baby. These are great for basting turkeys and for putting vodka in oranges.
Or watermelon.
Or watermelons, okay? But so for today's purposes, though, we want to get the vitamin C in here. So what you want to do is push your plunger back and give yourself 10, 20 cc's of air. So now when you puncture this highly pressurized vitamin C, it's going to flow automatically. Now, though, you have some air you can push back in. And so I can get some more vitamin C out. And you do this kind of tug of war, back and forth, until you've got about 30, 40 cc's in your big line, okay? Got my 30, 40 cc's? I'm going to push it into the large bag. See what Becky's doing? She's disconnected the bag from the pole, opened it up. She's got her 60 cc syringe and she's just squirting that sucker in. Okay? Then you're going to switch to the small syringe. By the way, you can only use 1 syringe per medicament. So if you're going to give somebody vitamin C, that's 1 syringe. Magnesium sulfate, that's 2 syringes. Sodium bicarbonate, 3 syringe. Procaine, 4 syringe. You can see when you move on to bigger and better things later on, you're giving somebody a Myers cocktail, you're looking at 10 syringes. So it does become a little pricey to give these people these IVs. You have to take that all into consideration when you decide how much you're gonna charge. I've been accused of undercharging. Everybody's always yelling at me, you're not charging enough. So you're gonna switch to a 3 cc syringe. And the 3 cc syringe is where you're gonna pull out your magnesium sulfate and your sodium bicarbonate. This is not as much of a tug of war, thank God. Okay, we want 1.5 cc's, 1.5 cc's of magnesium sulfate, and then 1.5 cc's of propane. If you like the patient, you can take a little bit more propane. If you don't like them, just give them a little. Okay, squirt it out, just throw it in the bag. Okay? So our bag is ready. By the way, she takes the bag and she does this very gently, just to kind of mix things up. Hooks the bag back up on the pole, make sure that the clamp is tight and you're not dripping all over the floor. Now your bag is ready for your patient. Now you go back to the patient. You're going to put the tourniquet around the arm. Now this is called fisherman's loop. It's not the way you tie your sneakers. Okay, when you tie your sneaker, you tie the loop around, up, and out. Correct? That's a knot. Here, you're going to tie around, but then just tuck it under and leave it there. The reason you do that is so that you can take it off quickly if you have to. You can pull on either string, boop, and it pops. So that's the first thing we'll practice in the office, is putting the tourniquet on. The tourniquet has to be on really tight because you want the pressure to build up in the blood vessels. You want the pressure to build up in the blood vessels so that when you prick with the needle, the blood flows quickly down into the line. Okay? Did you get that? All right. So you got to put the tourniquet on tight. How long can you leave a tight tourniquet on? Well, I had the pleasure of having a surgeon in my chair who does hand surgery. I said, oh, good guy to ask. I said, by the way, how long can you leave a tourniquet on? He said, well, the average hand surgery is about 2 hours, 2.5 hours. He says, and we keep a tourniquet on the whole time. Yeah, I was surprised to hear that. So when you get patients go, this is hurting. It's been on a minute. Yeah, right. Okay, too bad. Okay, too bad. The longer it's on, the better. Also, once you put the tourniquet on, have the patient drop their hand down and kind of do this thing, because that'll fill up the blood vessels better in the hand also. Also, before you get started and you do anything else after you've put the tourniquet on, you look around to make sure you have everything you need. A good chef always has their ingredients out ahead of time. They don't start chopping up the onions after they've already put the peppers in the pot. No, you have the onions and the peppers all chopped up ahead of time. That's a good chef. Same here. You make sure you have a small piece of tape available to hold the needle down. You have a second small piece of tape available to hold the tubing down. You have 2 long pieces of tape available to tape the arm to the board. Have all of that stuff ready, along with the gauze. I have 2 dental assistants. One of them is absolutely, I think the thought, and it's in front of my face. That's how good she is. My other dental assistant, I love her dearly. She's been with me 1.5 years. I still have to say, gauze, tape, other tape, and it drives me nuts. Sometimes I'm just like, just give it to me. Because I do dentistry the way I drive also very fast.
Blanche, you bring a good point that you're the one doing the stick.
Yes.
Okay. The dentists, at least in Texas, I don't know how it is in other states, don't have a duty to delegate a stick to an assistant.
Oh, no. No, you can't.
Okay,
delegate a stick to an
but I
assistant.
need for everybody to understand that.
Yeah. No, in all states, it's the doctor that does the stick, unless it's an EMT, somebody that.
You still don't have a duty to delegate, even to an
Right.
me being a paramedic.
No.
I realize that, or an RN if an RN came into your office. An MD would have a duty
MD
to
is
delegate,
the only
but
one
not
that
a
can delegate
dentist.
that. Right. So in the
Oh,
office.
so I couldn't have a nurse come in to do a
Correct.
stick.
You have to do it
You
yourself.
have to be the one to do
Oh.
all the IVs. You have to be the one.
Good thing I
to-
have a medical doctor that comes in and does.
Good, good, very good.
Yeah.
Okay, so once again, we put the tourniquet on, we make sure all of our ingredients are ready and within arm's reach. Okay, this in the old days, when we used to use alcohol swab, we don't anymore. We use ozone. If you do use an alcohol swab, because you're in Bangladesh and that's all you have to make sure you go like this and dry the alcohol. Because if you penetrate any alcohol in with the needle, it's gonna burn like heck. Alcohol burns inside the blood vessel. Probably causes some necrosis of the tissue too. Okay, so if you do alcohol, make sure it's burned, it's dry completely. If you do ozone, you gotta make sure it's dry completely too, because when you go to put the tape on, the tape will not stick to a wet hand. Okay, then select the vein. Feel it, feel it, feel it. Notice if the vein curves to one side and goes floop and tries to move away from you. If it moves away from you, you know you're gonna have to hold that baby tight, okay? Also, notice if there's a little, what appears to be a little bump in the vein. If there's a little bump in the middle of the vein, that's a valve. Now you can penetrate through a valve. Valves are like this, or I should say like this, okay? You can penetrate right through the valve and leave the needle there. I don't think it's a good idea. I just don't think it's a good idea. Because those valves are meant to be closed. And I would imagine if you have it open for 4 hours with a needle, it's going to be a little flaccid. And may not want to close completely afterwards. So I stay away from valves if I can, okay? And I think you should too. Now you're going to support, assuming you're right-handed, is to reverse, everything I'm saying from here on is reverse if you're left-handed. If you're right-handed, you're going to support the hand with your left hand. And I mean support it. I mean you grab that sucker and you hold it tight. Because almost all of your female patients, when you go to prick them with the needle, they're gonna do this. They're gonna back off from you. And so now you kind of, if you were fast enough to prick the vein, now they're bleeding all over the place, and you can't use that. Okay, so you're doing two things. Not only are you supporting the vein really tightly, but you're holding that hand and knowing full well they're gonna back off from you, okay? So I hold it tightly, I decide where the straightest path is. Mentally visualize the penetration of the needle. Take your time, because with these patients you're only gonna get 2 chances. They'll let you screw up the first time, you better get it the second time, because then after that I'll come in and give them their IV. Okay? You're only gonna get 2 chances to do this. Take your time, even if you keep thinking about it, this is where it is, this is where it is. And visualize, even if you have to put the needle next to the skin, how far in you can go before you get to a curve. You don't want to go to any curve. And know also, let go of the vein. See how it curves itself. Because you don't want to put the needle up to a certain distance and then find out when you let go, that part wants to curve. It's going to curve itself right over the point of the needle, now you got an infiltration. So really study the vein. Squeeze it, hold it tight, let go. Squeeze it, hold it tight, let go. See where that vein is going. And if you think you've got a straight section, you only need this much. The straight section that's going to stay put, that's where you're going. Okay? And then just as you're ready to put the needle in, say to the patient, and I mean a half a second before you're going to put the needle in, say out loud, little prick, or gonna sting a second, something like that, because those words are going to distract them. And while they're being distracted with, what'd she say? Boom, that's when you go in. Don't give them too much time, okay? That's when you go in. Okay, again, we use the small 23 gauge needle. This is the butterfly. Okay, when you squeeze the butterfly, you want to look at the bevel. The bevel should always be facing up. If you look at the needle and you don't see the bevel, then it's backwards, okay? And very often I'll tell my patients, oh, this is an infant scalp needle, the smallest they make. So they're kind of relaxes them. Oh, well, if this thing goes in the scalp of an infant, it must be pretty small, okay? Here comes the infant scalp needle. Smallest they make, you're only gonna feel a little pinch, okay? So butterfly goes up, you're holding the hand real tight. You see the letter C with my fingers? I'm pinching the vein here, I'm pulling it down over here, really stretching it out as much as I can. And I'll touch it once I've stretched it out to make sure it's not moving on me, okay? Now, when you come in, it's probably less than 45 degrees. You're not going down like this into the vein. It's more like an airplane coming in for a landing. So you're coming in for a landing, you decide where you're gonna go, and boop, that's it. Once you've entered the vein, you stop. Okay, again, like an airplane coming in for a landing.
Can you actually like pop, like does it pop like
Yes.
in your
You
tactile
will
sensation,
feel it.
you could actually feel
Yeah.
like a pop?
You will feel it, so pay attention to, and just talking, tell everybody, shh, be quiet. Pay attention, you will feel it.
I was taking that ozone course up at Phil Monica's office
Uh-huh.
a couple months ago, and they had a topical anesthetic like we use in the office, a benzocaine, but they had something that was formulated by a compounding pharmacy, and it was really potent stuff that you could put in your gums. I mean,
For
it
your gums, but
like,
it doesn't absorb in the skin.
I know because of the corny layer, but
Right.
if you put that on there, the cuticle would, ahead of time, would that soak through there, you think? I wonder if the real powerful stuff would work if you gave it like
Yeah, I don't know.
a few minutes.
My anesthesiologist always uses lidocaine.
Lidocaine? He injects lidocaine first?
It doesn't hurt that bad.
Yeah, it's just, we're just talking
To me, it doesn't make any sense because
Yeah.
she's poking
Yeah.
them twice. I'm
Right.
like, just stop with the lidocaine, I'm like,
Do it.
just get it over.
I had that discussion with my vet last week, because Santos broke his nail, what do they call that, the nail that's on fire?
Dewclaw?
Dewclaw, yeah, he broke it. It was hanging by a thread.
Ugh.
So here, mine is my baby. I got my baby in the vet, and I said, "Are you gonna give him some lidocaine first?" And he looked at me, yeah, like, he goes, "Lady, it's gonna take me longer to give him lidocaine than to just snip the nail." I went, "Oh, can I be in there with him at the time?" "No, you cannot." Out you go. I didn't even peep out at him. It was so cute. Then they put the little Band-Aid on with doggy paws. Oh, so cute. Anyway.
Shoot.
Okay, so coming in. You will feel the needle. This is your question. You will feel the needle pass through the dorsal wall of the vein. If you go in like a bull in a china shop, you're going to miss it. But if you go in slowly, you will feel it. Okay? Continue all up the vein only if it's a real large one. Otherwise, you don't need to. You really don't. As soon as you see blood flowing into the tubing, stop. You don't have to go up any higher. You're in. That's it. Most people are like, oh, they're gonna go. No, that's it. Stop. Put it in, boom, see blood. Hold the butterfly down. The dental assistant will give you the tape, and if you're by yourself, you grab the tape, and you're going to put it on the, I would say the medial side of the blue butterfly. You have got to leave half of the blue butterfly exposed, bless you,
Thank you.
so that when it comes time to take the needle out, you can hold on to the butterfly and rip the tape off. If you don't leave half of the butterfly exposed, how are you gonna take the tape off later on? Okay? So she's handing me the surgical tape, and the surgical tape is placed here, and if you notice, at the distal end of it, the butterfly is exposed. Okay? And you notice there's some blood in the line. Now, if this end of it is sealed and closed and it has a cap on it, a lot of times the blood will just flow a little bit and stop. When you open up the cap,
Bloodletting.
it goes fast. So you don't open up the cap until you're ready. So that's the first step. She tapes it down. Now, I will go and reach for my tubing. I have my tubing in my right hand, I got that in my left hand, Now I will open the cap. The dental assistant will give you a second gauze to put underneath these two. And so now you've got your tubing in your right hand with the vitamin C. You've got that tubing in your left hand. You've opened the cap and you're watching the blood flow. Loop, de-loop, de-loop. And you're patiently watching the blood flow until it goes all the way to the end. And then you hook up your vitamin C line to your blood line and try not to get a bunch of bubbles because the patient's going to freak out. Okay? Allow the blood to flow. Now, do you see what I mean? I have a gauze in my hand. Allow it. I'm holding, this is my vitamin C line. It's open at this end. I've opened this one. I'm watching the blood flow. When the blood gets right to there, I'm going to hook the two of them up. And then you open up the clamp all the way, quickly, to make sure that the blood flows right back as soon as possible. The longer you leave the blood in the tubing, the better the chance of clotting. Then you'll have a problem, okay? So open it up, let the blood flow, and while it's flowing back, then we take the second piece of tape and hold down the line. Okay? You should have reverse blood flow. When you have reverse blood flow, that's when you're going to look to see if you got a good hole or not. Because if you see ballooning right here, and it's swelling up, whoa, that means you went through the vein. Okay? And so at that point, you make sure the tourniquet is off, you shut your line down, you take out the needle, because you left half of the butterfly there, right? Hold the butterfly down, take half the needle out, and hold it for 1 full minute. If you hold it for 1 full minute, and I like to hold it for 2, if I'm going to use the same hand, 2 minutes, you can put the tourniquet on the same hand. But you've got to make sure that that first one has clotted, okay? You can even go like this. Squeeze, make sure it's not going to bleed again. Then put the tourniquet on if you're going to go for a second vein. Most of the patients will tell you, no, use the other arm. Okay. All right?
What is, like if a patient has breast cancer and they've had lymph nodes removed?
You cannot use that arm.
Yeah, just bring that up.
Yeah, you cannot, yeah, thank you. Yeah, you cannot use an arm that has had lymph node removed. Okay? And then ask the patient if it hurts. Very often they'll just tell you it feels cool. If it feels cool, that means that the fluid is going through, and that's okay. Then we secure, if everything looks good, you secure this part with another piece of tape. Try not to put the tape too close to the needle because you might move it. All you have to do is put a piece of tape here, and then the dental assistant will give you the board. You tie the back, you tie the fingers, and now the hand is nice and secure on the board. Okay? Yeah, that's what it looks like. This is not nice and neat and gorgeous the way you see it in the hospital. We don't care. I'm just gonna have it in there, for a couple hours. Okay, count 6 seconds and then multiply by 10. So you can say to somebody, okay, give me a go. And they say go, and you count the drops. Then multiply by 10, and you want about 55 drops per minute, right? So you never want to go past the number 6 when you count it. That's 55 drops per minute. You get some patients who are in a hurry, when you're not looking, flick.
So
They open up the stitch.
So you want mini drips?
Mini drips.
Okay.
These slides are not in our notes.
And then not?
Mm-mm.
No.
But for
Well, this
those
is for IV
for those that are
squeeze.
placing orders, you might tell them the difference between a mini drip and a maxi drip.
Yeah, I don't know. Mini drip I know is a smaller hole, but I don't know what the actual number is.
60 per
60 per minute is a mini drip?
and the other is like a 15.
Oh, okay,
That's a maxi drip. That's if you're trying to get fluids in
Right.
faster.
right.
But when you're ordering the
I may go
tubing,
with a maxi drip and just slow it down myself. You can, because you're controlling it with your wheel. Because if I'm giving them a sedative or I'm giving them some glucose,
we'll look at the
I want
office
to
and
go
see what you have
slower.
as mini drops.
Yeah, that's
You can
cool.
tell by the size of the white tube that's inside that white the clear squishy thing.
yeah.
If it's a bigger hole, then it's
Okay.
a maxi drip. If
You
it's
let
a
me know.
smaller one,
I don't know what I get.
okay.
Okay, the critic here, we've already went over this. It only works if the doctor will listen to the whistles and bells. And that's what that looks like. And that's, if you're interested in anesthesia, these are great people to talk to. Wait, anybody want to get that? Oh, you have the number. Do you have the number? Do you have this?
I have it on the slide.
Oh, okay. 732-469-9000. 9054.
50.
9050.
I kept her up.
Okay. Hey, perfect timing. It is now 10 to 12. We're gonna go to the office.
Oh yeah, we're done
Okay.
here.
Yes. We're gonna, okay?
Diane,
Okay.
I'm gonna put this in the kitchen.
Now you're going to pinch the bladder once and see if you got enough. The bladder, Mike, at the bottom.
Hold this?
There.
Okay.
Okay, so you see Hans perfectly got his half full the first time around. Good. Keep going, Mike. Okay, Mike, yours is, your white pointy part is not in deep enough.
Not in deep enough.
All right.
Mine wasn't either, mine.
Okay.
I've had that problem all my life.
This one here isn't.
She isn't? Oh, how about that?
No, I can
What nationality are you?
push it back in.
No. You want it to be in there. That's what you're trying to do is get it in here. You want
Get it in
25.
there. So is it
Okay.
okay to pull it out, put it in there, and go back a second time into this bottle?
Yep.
Okay.
Until you get 25 cc's in that syringe.
Oh, that's all? Okay.
Yeah.
25 is all you want? Or you want?
I thought we were doing the whole bottle, sorry.
I think she wants just 25 cc's. They're
Okay.
trying to draw out the whole 60 cc's.
Yeah, no, that whole bottle is 25 grams.
That's what I thought.
25 grams or 25?
25
25 grams.
Not
Okay.
25 cc's.
That whole
Okay.
bottle is 25 grams.
Okay, so we want the whole bottle in here.
Right.
Oh.
And then just
Now,
come
you can do
into
it one of two ways. You can put it through the bladder,
Or you come into here,
or you can grab the whole bag, which is what is much faster.
turn it upside down.
Turn it upside down, take this out, hang this up, if you don't want it to touch the floor, and just squirt it into the open hole.
So just take this all out.
Yep. Now you hold on to your needle, because when you let go,
Yep.
right, very good, you got it.
Thanks.
So then you have something to.
Don't take that off.
No, don't take that off.
No, if
Oh,
you're
go
gonna,
through it?
if you're gonna do it that way,
If you're gonna
inject
do
it
that
into
way, Go
it.
right through it.
Go right through it.
Okay. Now we're going back again with the bottle, right?
Yep. Pull out the rest of the vitamin C. No, I got a better idea. Let's do it together. Ready?
Wait, is that on tape?
Yeah.